I'm Kristin Meharry. I'm a family nurse practitioner. I work over at the Orthopedic Institute with Dr. Deviney. So we're going to talk a little bit today about the treatment and diagnosis for osteoporosis. A lot of people have heard a little bit about treatment for osteoporosis. Either they've had a friend who's been treated, and there's a lot of information out there, but it's not always the correct. So we kind of want to address and give you the proper information today so you can make the choices. These are our objectives today. So we're going to look at osteopenia and osteoporosis, how it's diagnosed. We're going to talk about the Dexa Scan. We're also going to look at how to rule out secondary causes of bone loss. We'll review a little bit about what Dr. Deviney talked about. It's important to understand the cells that affect the bone because the medications you take affect those cells. So it makes sense if you understand what the drugs are doing. We're going to talk about treatment options for lifestyle change and as well as pharmacological treatment for osteoporosis. All right, and I have a little video I just want to kind of show you. I get to meet a lot of people who have had fragility fractures, and they're all different. There are people who are very active. There are people who have had a lot of diseases that have limited what they can do. So you hear a lot of different stories, but osteoporosis can be in anybody. There's younger people, older people. I'm seeing people in their 50s who are getting fractures, hip fractures already in their 50s. So it's really important to kind of realize it could be anybody that could go through this. Just kind of want to put a little face to it. I mean, it's people from all walks of life who've gone through this, and the impact it can have on your life is pretty huge. We're going to look at diagnosis next. A real important part of the diagnostic process is the history and physical. History in particular. Dr. Deviney talked about some of the risk factors for osteoporosis. Well, this is where we determine that by sitting down and taking the time to go over your history, the past medical history, any history of cancer. Did you have chemo? Did you have radiation that could have caused weakening in the bones? Inflammatory diseases such as rheumatoid arthritis. Often those are treated with steroid medications which are hard on the bone. He had mentioned celiac disease or gastrointestinal diseases. They slow your absorption of calcium. So even if you're eating foods rich in calcium or taking your vitamins, you might not be getting it to your bones to help them. Any history of low calcium or low vitamin D in the past that you were treated for and maybe never got a follow-up to see if you had improved your levels. Kidney disease is really a big hit to your bones that affects your calcium and your vitamin D levels and can lead to osteoporosis. History of kidney stones even. If you have a history of kidney stones, particularly ones made of calcium, that's going to affect how much calcium we give you, so it's important to know that as well. Social history, we need to know, did you smoke? Did you, even if you quit, did you spend a long time smoking? How much alcohol do you take in? How much caffeine do you take in? Because those all affect your bone health. He mentioned briefly also medications. Steroids are the big hit to the bones, and a lot of diseases, COPD, inflammatory diseases are treated with chronic steroid use. If you're on a steroid like prednisone for more than 3 months, that's considered a risk factor for bone loss. So it's important for us to determine that in the history. Other medications include Prevacid, Prilosec. It's a group of medications called proton pump inhibitors that treat acid reflux. If you're on that long term, and I've had plenty of patients who've said I've been on it for 20 years, that will also cause loss of bone density. Some other ones include anti-seizure medication, medications to treat depression or mood disorders. Family history is important, as Dr. Deviney mentioned. Did your mother break her hip when she was older? Did your father have a back fracture? That's important. There is a family link for that, so it's important to know that in your history. Review of symptoms. Have you had chronic back pain? You don't always have, like in the little video, you don't always have an acute episode of back pain when you break it. A lot of times the bones just kind of crumble in there, and so you get chronic low back pain. You think you pulled a muscle, you lifted something you thought just kind of made your back hurt. So you could have this chronic low back pain that could actually be osteoporotic changes in your spine. So that's important during the physical exam. Height and weight are also very important. We measure how much you've lost in your height. That's a risk factor. You can tell us if you've lost height. You guys know if you feel like you've gotten shorter, your clothes have changed, everything. And then we keep track of it too and measure it to see if there's changes. One of the gold standards for testing for osteoporotic or bone density is called the Dexa Scan. It's dual energy X-ray absorptiometry. It's a fancy word. Dexa is easier to say. It's a very simple test. It takes about 10 to 15 minutes to do. It's a low energy x-ray. You can do it of your lower back or the lumbar. You'll hear people say L1, L2 fractures. That's your lumbar area. And they also do it of your hip. They do it of your total hip and also the femoral neck, which is a narrowed portion of your thigh bone, the femur. Those are the gold standard places to check for osteoporosis. Some people will also have it done of their wrist, but typically if we're going to talk about treatment, we'd rather have it done on your lower back and on your hip. And what's important to know about that, and it's important for you as advocates for your own care, is to understand a little bit about what the results mean. A lot of times you'll get a test, the doctor says it looks good, it looks bad, but you don't really know the difference and what the results mean. It gives you what's called a T-score. What they do is they compare the density of your bones to a woman who is 30 years old. They use that, and however far off from that, which is your peak bone mass, however far off, they call it standard deviations, how many you are away from that, usually going negative in the score, will tell us if you have either osteopenia or osteoporosis. To verify, not everyone knows the difference. Osteopenia is where you have had some loss in the density of your bones versus osteoporosis, where you've had a major loss of bone density. And you can kind of see the difference on, it'll be your left, you see osteopenia, the middle is normal bone, and then you can see the big difference by the time you get to osteoporosis. So if we can catch you in osteopenia before you've moved over to osteoporosis, you can see that's quite a difference in the density of your bones, which will decrease your risk of fractures. So this was what we do with the T-scores. When we do that test, we get a report back that shows us the T-score. And we're looking at your lower back. There's 4 different levels we look at, and we look at your hip. We can either do one hip or both. And we get a T-score. Normal is negative 1.0 or higher, so going more positive, like 1 or 2. Osteopenia, so you've lost some of the density. We're looking at negative 1 to about negative 2.5. If you're negative 2.5 and lower, so negative 3, negative 4, you have osteoporosis. Severe osteoporosis is considered less than negative 2.5 with a fragility fracture. Okay. So it's important to know that, because like any other treatment, you want to know if the treatment's working. So we can look at the difference on your T-score after treatment. That's one way to see if the treatment is actually effective for you. So that's why we do repeat scans to look at that. There's a lot of screening recommendations out for people. There's different organizations that say when you should get screened and how often you should get screened. The U.S. Preventative Services Task Force, the USPSTF, it's kind of one that we use often to determine how often women or men should get screened for different diseases. They recommend, and I don't have it there, bone mineral density is supposed to be if you're greater than or equal to 65 years old. Or if you are younger than that, if you're under 65, if you have risk factors, is basically what they say. So that's why the history comes in. If you're younger and have had a fracture, you need to come in and let's look at it, because we would do a bone density on you even though you're not 65 yet, because you have a risk factor or you've had a fragility fracture. If you've had a fragility fracture and you're over 50, even if your bone mineral density just says that you have osteopenia, the guidelines still say you would need to be treated. So that's where the bone mineral density test isn't necessarily the be-all, see-all, because you can still need treatment even if you're saying it's just osteopenia on there, if that makes sense. So it's a part of the information, but you still may need treatment even if you have osteopenia versus osteoporosis. Screening for men, typically osteoporosis is in females, but males can also get osteoporosis, and they can get it at younger age and they can get it at older age, depending on risk factors that they've had throughout their lifetime. So the decision typically to screen is related to the risk factors present. If you've had to be on steroids, if you've had some type of disease process where you haven't been able to do a lot of weight-bearing activities, so you haven't had a lot of stimulus to your bones to stay strong. These are all risk factors. Certain diseases that we talked about, if those are present, then you would definitely need screening earlier. Like I said, there's a lot of different organizations. The National Osteoporosis Foundation, a lot of times that's what we'll go by. They recommend that if you're women, 65 and older, and postmenopausal less than 65, with risk factors. You need to be screened. And they agree that men 70 and older and need to be screened, and then if you're 50 to 69 with risk factors. Okay. There's another tool called the Vertebral Fracture Assessment. It can be used in conjunction with the Dexa Scan, so while you're getting your Dexa Scan, you can also have this done. It looks at the vertebral imaging. You can do an x-ray on your back to look at your spine. It uses a higher dose of energy, and then if you do a CT or MRI, those are more involved processes. This actually will give a degree and location of any fractures that they see in your spine. So it's something that could also be done to screen when you do your bone mineral density test. The recommendations for that are women if you're over 70, men over 80, and then if you've had risk factors. If you're a younger age, we can do it if you've had risk factors like a fragility fracture or you've already lost height. And that would be an indication that we need to go ahead and do this test prior to the age. This is also a very important tool. We use this on all our patients that come into the clinic. It's called a Fracks Calculator. The World Health Organization recommends using it. Basically, we plug information in there that we received from the history and physical that we do with you, such as family history. Have you had a fracture? We plug in the T-score from your femur, and it gives us a percentage. What it looks at is the percentage of risk for a major osteoporotic fracture in 10 years or a hip fracture in 10 years. And the clinical guidelines for treatment say that if your major osteoporotic fracture risk is 20% or higher within the next 10 years, and or the hip fracture risk is greater than 3% in the next 10 years, you need to be treated for osteoporosis. We also look at possible secondary causes of bone loss. There are other disease processes and medications that can cause your bones to become weaker. So if that's what's going on, we need to rule that out because that might require a different type of treatment to reduce that risk to the bones. These are just some examples, and we've talked about the gastrointestinal disorders, endocrine disorders. Parathyroid hormone is one thing that we check if you've had a fragility fracture. It controls the calcium level, and so if you have a disorder with your parathyroid hormone, it can actually pull calcium out of your bones and cause a weakening of the bone. So if that's happening, that needs to be treated prior to looking at osteoporotic treatment, because if you don't fix that, you're not going to fix the problem. Musculoskeletal disorders, we're talking about disuse. So if you have an issue where you're not able to walk as much, you have weakness in the legs, or not able to keep the weight-bearing activity, you can have bone loss. Same with spinal cord injuries. You're not able to be up and about. We also do some lab work. There's a lot of labs up there. The good news is it's usually one blood draw, and you can also do a urine test. What this looks at is your metabolic profile. We can look at your calcium. We can look at your vitamin D. We can look at those other secondary causes and rule out those as possibilities. Treatment options. So the universal recommendations are the same for prevention of osteoporosis as well as treatment for osteoporosis. In other words, nutrition, you're going to look at dairy foods, fruits, vegetables, whole grain. Calcium-rich foods, you're looking at dairy, such as milk, cheese, yogurt is a good source, as well as kale, spinach, dark green leafy vegetables. There's also, if you can't do those because of health reasons or you just don't like them, there's a lot of calcium-fortified juices and foods out there, and you can do those. If you know you don't typically eat foods high in calcium, look for calcium fortified on the label. That's a good way to get your calcium in. Tobacco. Can't say enough about quitting smoking. And if you're smoking, you've heard it before, it's very hard on the bones. So try to avoid tobacco, and then even secondhand exposure is hard on the bones. Alcohol, we consider excessive alcohol take as if you're doing 3 or more drinks a day. Definitely can lead to bone loss. Same with caffeine, limit to less than 3 drinks a day. And that's tea, coffee, soda, sport drinks. All of those can have caffeine in them. Weight-bearing and strengthening exercises are very important to maintaining your bone health. Weight-bearing stimulates bone growth, so that's why it's so important. And fall prevention, which we'll talk a little bit more. If you have osteoporosis, fall prevention is very crucial to help preventing fragility fractures, and there's things you can do to help decrease the risk of falling. The AACE is the American Association of Clinical Endocrinologists, and they're the guidelines we use for treatment decisions for osteoporosis and osteopenia. This is their recommendations for their daily calcium intake. So you can see it's pretty close to the same for most of the categories. So looking at the 51 to 70-year-old males, 1,000 is the recommendation. That's milligrams. Same for women. So 51, we're talking usually postmenopausal, to 70 is 1,200 milligrams. And greater than 70-year-old males and females, also 1,200. And the important thing about calcium is take it in divided doses. You never want to take all that at one time. It's a little bit hard on the gut. So you split it in half. You take one in the morning, one in the evening. It's also important, if you know your diet and you know you get in quite a bit of calcium with the foods that you take in, that 1,200 or that 1,000, that's food that you take in as well as a supplement. So if you have a really good diet and you can get that calcium in, it's important to factor that in. Calcium coming from foods is the way your body's used to absorbing it. So if we can keep it that way, we'd like to. I get a lot of questions about which calcium to take. You go to Walmart, you go to a pharmacy, and you're trying to grab a calcium supplement, and you see a lot of different labels and a lot of information. There's two main types, calcium carbonate and calcium citrate. Not a whole lot of difference. The calcium carbonate's the most often used one. It's less expensive. It requires fewer doses to get the amount in. The main issue with that is GI issues. It can be a little bit rougher as far as constipation, bloating. That's why we always say take it with food. If you try taking it without food in your stomach, you will have more issues with it. The calcium citrate's a little bit more expensive. You can get less doses through the day to get your amount and less GI complaints. This is like what we talked about as far as looking at what you eat. It's a real simple way of looking. So if you drink a glass of milk a day, 8 ounces right there, you've gotten 300 milligrams of calcium. So it's really important to keep track of what you put in your body because it's not just food, it's also nutrients. And so this way you can kind of have an idea of what you're already getting in your diet. Vitamin D, you hear a lot about vitamin D. It's kind of a powerhouse little vitamin, almost acts more like a hormone. We see receptors for it in almost every system in our body. So it has a big impact on just about everything that we do. That number up there, the 25 OHD, that is how we check the level. That's the actual name of what we look for when we look at your vitamin D level when we do blood work. The recommendation is to be above 30. It used to be when people were outside more, doing more physical labor outside, having exposure to sunshine, they had higher vitamin D levels. When the sunshine hits your skin, it actually creates the synthesis of vitamin D. So when we were outside more, doing more outside activities, our levels were actually usually around the 40s. And they've actually studied people who have been out working, and they tend to stay higher. But we usually prefer over 30. If you've had a fracture, we'd rather keep you higher up, 40 or 50. So it's important to monitor that. You can see on there it says vitamin D has been shown to decrease the incidence of fractures. It improves muscle strength. It helps with improving balance and decreasing your risk of fall. So it has a big impact on kind of all aspects that affect osteoporosis and your risk for fragility fractures. After you have a hip fracture or you break a pretty significant bone, you actually have a decrease in your vitamin D levels. So that's especially why it's important after a fracture to be on vitamin D supplement if you aren't already on it. There's two different types of vitamin D supplementation, kind of like the calcium. The ergocalciferol, big fancy name, it's vitamin D2. And typically on the label you'll see D2 or D3. Either one you will be okay with. There's not a whole lot of difference. D3 is just more like what your body makes. D2 is more of a synthetic version. But it will not be that big of a difference if you take either one. Here are the recommendations so you can see. There's a lot of variation as far as the recommendation. It's why it's important to get your blood level checked, because if you're low, we're going to put you on a higher dose. It's very hard to get a toxic level of vitamin D, but it is important to monitor your vitamin D to make sure you're on the right amount, because you may have to be on a higher level for a briefer time to get your level back up to normal, particularly if you're recovering from a fracture. Exercise, we talked about exercise being important. So I have kind of a do's and don'ts of exercise. Weight-bearing exercise, daily if you can. If you can't do it daily, try to aim for 3 days a week. If you work out on Monday and miss Tuesday, the effects from your workout on Monday are still working in your body on that day you skipped on Tuesday. So don't feel like you failed by missing a day, because the positive effects you had from that first day of walking are still going on. So we're talking about walking, jogging, stair climbing. Tai Chi is wonderful. I don't know if anyone's familiar with Tai Chi. They have good classes here in Tyler, but it's very slow. It works on your balance. It works on strengthening. It's a very slow movement, and shifting of your body weight helps with your balance, strengthening, and your weight bearing while you're doing. So it's helping with your bones. It's also helping with your balance. Muscle strengthening activity 2 to 3 times a week. We're talking about weight training, even if you have just simple 1 or 3 pound weights and you're moving, or the bands and you're doing that for tension. That's also important to keep your muscles strong to help with your balance. Posture, talking about standing, sitting, working on your activities of daily living. Your posture, when you go from a changing position from sitting to standing, is important. Keeping your back straight, making sure you have your feet planted, and that you're using proper body mechanics to move. That's all very important. This is what not to do. Okay. So, and that one, definitely don't do that. No jumping in the air. So if you have osteoporosis or you've had osteopenia or you're at risk, you want to avoid exercises with forward flexion, so bending forward, twisting the spine, toe touches, sit-ups like that. That puts more pressure on the bones. If you already have had bone loss, you don't want to risk a fracture while you're trying to exercise and stay healthy. Avoid high-impact exercises. One rule they say is keep one foot on the ground. So you don't want to do anything that's heavy and you leave the air, puts you more at risk. Fall prevention is very important. You can do physical therapy. Sometimes we'll do a physical therapy order where they actually work on your gait, so to help, because it's really important. Sometimes you'll turn and rush to do something, you've forgotten something, you spin around, grab it. Stuff like that you need to kind of avoid, and they actually will teach you proper ways of turning, keeping your feet planted, knowing where you're going, taking different steps. Physical therapy can be a real key to helping with decreasing the risk of falls. Anchoring rugs. Rugs are pretty brutal for falls. A lot of people have throw rugs in their house, and it's so easy, and I've done it myself, of catching your toe on that rug and you're on the ground before you know what happens. Minimizing clutter. If you've got like bags on the floor, something that you just, if you're coming around that corner fast, you can trip over. Lights, proper lighting is really important. A lot of falls happen when people get up at night to go walk to the bathroom, to use that restroom, and you know it's your house, you know it, and you don't flip on your lights, and you trip and you fall. Bathrooms are pretty common for falls. Shoes are important. You don't want to be on anything that's wobbly. Flip-flops are pretty bad for falls, so you want something that's supportive. Hip protectors, they look a little bit like bicycle shorts, but they actually have padding. If you've had previous hip fractures, you've had pretty severe osteoporosis, some people have recommended using these hip padders. So it looks like shorts that fit like skin. They're pretty tight. And they have padding over the hip joint, so that if you do have a fall, particularly if you have a disease like Parkinson's, where your balance, you're not going to be able to do a whole lot to improve that. This would be something they could do to help protect if you do fall and reduce your chance of a hip fracture. Okay, so pharmacological treatments. Now we're talking about medications we can use to treat osteoporosis and osteopenia. So the recommendations for postmenopausal women and men over 50 or 50 with a hip or fertility fracture, vertebral fertility fracture. So if you've broken something in a low velocity, so you've tripped and fallen, stepped off a curve and fallen and broken something, the recommendation is now, even if your Dexa Scan shows just mild osteopenia, the recommendation is you need to be treated for osteoporosis. You also need to be treated if your T-score, like we talked about, is less than or equal to -2.5 in either the thigh, the hip, or the spine, or if your T-score is osteopenic and your Fracks score that we talked about is indicating that you're at risk for 10 years for either a hip fracture or a major osteoporotic. So those are the guidelines we use to determine if we're going to treat. Okay. This is just showing, right now they're working, it used to just be if you showed osteoporosis on your Dexa scan, then you got treated. If you showed osteopenia, take your calcium and vitamin D, and we'll follow back up in a couple years. They're trying now, they're realizing that's not working. 2 million fractures a year, it's obviously not working. So they're showing now that we need to go back, we need to go earlier and bring people into treatment to try to prevent it from getting to the point where you're breaking and you keep repeating your breaks. So now they're looking at, if you're younger, we need to be screening and we need to bring you in and start treatment sooner. Okay, so the 2 main categories of medications for osteoporosis are what's called anti-resorptive. So Dr. Davidi mentioned osteoclasts and osteoblasts. Clasts chew up bones, blasts build bones. So anti-resorptives means you're slowing the reabsorption or the breakdown of bone. So those drugs all work on osteoclasts. They don't build bone, they help prevent bone loss. The anabolic is building up. They work on the osteoblasts. It's the only category that actually builds new bone. So as you can see, we're kind of unbalanced. We have a lot of drugs that work on the cells that tear down bone. We've only got one that works on actually building up new bone and healing fractures. This looks at bisphosphonates are our biggest category of drugs. This is one most people have heard of or know somebody that's taken a bisphosphonate. Fosamax, Boniva, Actonel, Reclast. These are the ones that are most common. Fosamax has been out there the longest, and they are a good category of medications. They work on those cells that tear down bones. They slow bone loss. On this chart, you can see these are the top ones that are most often prescribed, and you can see if they have a check mark under spine, they help reduce the fractures in the spine. Check mark under hip, they reduce fractures in the hip. Non-vertebral means we're talking about proximal humerus, so the top of your arm, or wrist fractures or ankle fractures. The Fosamax is just a pill. You take it 70 milligrams once a week. You can even do a once monthly dose. Boniva you can do IV, means the main side effect for bisphosphonates is you can get some GI upset. You have to take it with a full glass of water on an empty stomach first thing in the morning. You have to then stay upright for about 30 minutes. You can walk around, you can do whatever, but the main thing is you want to get it so that it goes down to your stomach, doesn't get caught in your esophagus. So if you have problems with your GI tract, you have a lot of upset stomach, a lot of issues, there are options that you can do it IV, so through the vein, versus having to take a pill. So there are several options as far as the ways you can take it. It's been shown in clinical trials that using bisphosphonates, you reduce your risk for spinal fractures by about 50%, with hip fractures, for these particular bisphosphonates, about 40%. They are the first line choice due to the efficacy, so they are effective. Cost, Fosamax is the only generic one out there right now, and long-term safety data. Reclast is an IV alternative like we talked about. We talked about some of the adverse effects. GI upset, it can lower your calcium level. Now the main thing with bisphosphonates is there are two risk factors or two complications that you can get with long-term use. So osteonecrosis of the jaw can actually cause some erosion of the bone in your jaw. Oral care is very important on that. You should be going to your dentist once or twice a year already to get cleanings and care. Typically we see that, and then the atypical femur fractures if you've been on it too long. One of the problems with bisphosphonates is you get put on it and then you're on it for years and you don't really get checked to see is it effective. The recommendation is about 3 to 5 years on a bisphosphonate. I had a patient the other day that's been left on it for 20 years. So you get put on it and then you figure it's doing what it's supposed to be doing, and then it slips through the cracks and it never gets followed up. Well, the longer you're on it, you can get complications. The 3 to 5 years, the benefits far exceed any risk. If you're on it over 5 years, that's when we have seen some risks with it. So it's real important to be taking it for the proper length of time. The atypical femur fractures. So there was a warning from the FDA that you can get this, and this is what we talked about, if you've been on a bisphosphonate for greater than 5 years. But look at the risk, less than 0.1%. Okay, so it's a very small risk, but it's something that you still need to be monitored for. So we'll usually ask you, you need to tell us if you're on this medication, if you get any cramping, any groin pain, any thigh pain. It's not usually a dramatic, but you just get kind of achy with it. So then we come in and we do an x-ray to look for any stress fractures in the bones. There are some patients that need to be on it for longer term. You've got patients who have actually had some progress while on it. You've got some patients, like those transplant patients or patients with severe COPD, who have to be on a steroid for the rest of their lives. And so the bisphosphonate has been shown to work, and we know this by watching their Dexa scans and measuring their height. And so if they're actually working for them, then they may need to stay on it for a prolonged period of time, in which case we'd continue to monitor for any complications. This is kind of a summary of the other options on those medications that slow bone loss. Denosumab or Prolia is a drug that's been very effective. It works on the receptors where those osteoclasts latch on and do their business. So it helps block it. And it works on reducing spine, hip, and non-vertebral fractures. You get an injection, small little injection into the tissue every 6 months, and it's been shown to be effective. Raloxifene or Evista works on your hormone. Estrogen for women helps keep your bones strong. The issue with why everything is postmenopausal is when that estrogen level is gone or dropped, that stimulation to keep your bones strong by that hormone is gone. And so the cells that are breaking down are a little bit more effective than the cells that we're building up. Estrogen is really not recommended. Estrogen would be talking about hormone replacement therapy, particularly after menopause. That's one where we would really have to talk and figure out if the risks outweigh the benefits. So if you're over 50, you're going through menopause, and they're talking about hormone replacement, that's where sitting down and going over your risk factors for osteoporosis would be important. If you have a family history, you have several risk factors for osteoporosis and bone loss, a brief period of hormone replacement might be effective in helping slow the bone loss you'll experience after menopause. Calcitonin is a hormone that works in the body, and it actually helps keep your bones strong, slow bone loss. It doesn't build bone, but it helps slow bone loss. This is actually a nasal spray, so like you would use any type of nasal spray for allergies, same effect. You can actually just squirt that into your nose daily, and that helps slow bone loss. And it got the Prolia then, or actually teriparatide, we'll cover that one next. That's actually Forteo. That's our only bone building, so we'll talk about that in just a minute. So these are the two hormone-related drugs. A little more risk when you're dealing with hormones as far as side effects. With the Evista or the raloxifene, it's non-hormonal, but it acts on the hormone receptors, so it does affect your hormones. It reduces spine, but not hip or non-spine fractures. So if you have already had some vertebral fractures, or you've had an issue with your back, this might be one to be considered. It also works on the cells that can affect breast cancer. So some women who've had breast cancer, particularly hormone receptors, they are on this because it reduces that risk. The big risk with these are you can get blood clots. Any types of hormones that can affect blood clots. So it's real important if you've had a blood clot in the past or you have other risk factors for blood clots, this would not be the medication for you. The estrogen, the hormone replacement we talked about, but with estrogen and hormone, the big adverse effects that they found, which is why not many people are on the hormone replacement therapy like they used to be, is if you're on it too long, stroke, breast cancer, blood clot, and pulmonary emboli. So that's why it's one of our last resorts as far as what we would do. The calcitonin, we talked about that. Prolia is a really good medication. One of the main reasons we like it is because your kidney function is usually a determinant of what medication we can put you on. If your kidney function is decreased, it really limits what medications we can give you because the kidney filters so much of medications that we need to be cautious. Prolia is one of the few that even if you're on dialysis, your kidney functions are so bad, you can be on this medication. So we talked about earlier with kidney disease, you can get osteoporosis. So for our kidney disease patients, this is a wonderful drug. Even if your kidney function's good, it works. So it blocks the receptors where those osteoclasts work. So it slows bone loss. So it can be a first-line agent, and then it can also be used when you're switching between medications. This is our only bone-building medication. It's pretty exciting. It's called teriparatide. The brand name is Forteo. It's the only one that actually builds bone. It was used initially after vertebral fractures. A lot of the spinal doctors were using it to help repair the bone because it would build back up the bone that had been lost and help heal fractures that had occurred. It reduces both vertebral and non-vertebral fractures. It's an injection. I'll show you in a minute. There's a picture. It's a little pen. Looks literally like you have a Sharpie marker. And you give yourself an injection either in the outside of the thigh or your belly once a day. The needle is smaller than an insulin syringe. Very tiny, tiny needle. But it actually helps build up bone. You can only take this for about, the recommendations are 18 to 24 months. When they did the clinical trials for this medication and the rat trials where they were testing it on the rats, they had a small percentage that developed osteosarcoma. So they limited. They found that if you did it more than 2 years, your rates increased. They have tracked this drug after they released it to make sure that there was no incidence of osteosarcoma. They're very dedicated to watching that. They found that your risk for developing osteosarcoma, which is cancer of the bone, was less or equal to what your risk would be if you didn't take the medication. So it's not really an inhibitor to using the medication. It maintains your bone growth, but what you need to do is, if you're on this, say you're on this for 18 to 24 months, when you stop taking it, we usually transition you over to another medication, such as Prolia. If you just stop taking it and then don't take anything, that bone that we build up, you can lose it. So it's important when you stop taking this that you follow back up and make sure you're still on a treatment to help keep that bone growth that you've had. Adverse effects, if you've had a history of bone cancer, if you had a history of Paget's disease, which affects the bone, you've had radiation due to some type of process, bone metastasis, if your calcium level stays chronically high, or you've had the history of bone cancer, all of that are your risk factors, and that would be a reason you wouldn't be able to take the teriparatide. It's very important if you've been started on treatment for osteoporosis to keep getting checked. I see a lot of people who say, I've got put on Fosamax, and how many years ago? They can't remember how long they've been on it. They just know they've been on it a long time, and they ask, how long has it been since you've had a Dexa scan? Oh, about 10 years ago. Yeah, and they don't get followed up on. And so that's a problem. If you take a blood pressure medication, you go back in at least every year to get monitored to make sure it's working and that your blood pressure is under control. Should be the same for your bones. If they put you on something for your bones, you need to be monitored to make sure it's working. And like we talked about with bisphosphonates, you don't want to be on it for long term. So you really need to keep track of that, and that's where being a patient advocate is so important. Compliance with bisphosphonates is only 45%. So that's been an issue too, is you get put on a medication because you got told you have osteoporosis, and maybe you had some of the GI effects, and so just stop taking it, and then you don't follow back up. As you can see, there's several medications out there, so you can be worked with to find the combination of the medication that works for you with the least amount of side effects to help. So it's really important to stick with it. I thought this was interesting. So secondary fractures, we talked about 2 million fragility fractures a year. So we see patients that come into the hospital, Dr. Davini sees them, treats them for a hip fracture, or treats them for a proximal humerus fracture or ankle fracture. So 2 million, so this is the pile of casts that they compile to represent in a year how many fractures come through. You can't see it, but literally if you picture about maybe a third of the way up, that's the top of a human's head. So that's a pretty significant pile of casts representing the fractures. We have started a fracture liaison service. We talked about Own the Bone. ETMC joined with the American Orthopedic Association's Own the Bone to try to work at making sure that we can decrease the risk of, if you've sustained a fragility fracture, let's try to prevent you from having to go through it again. So in adults, if you're 50 or older after a fracture, we come see you and we talk to you. What are your risk factors? Have you ever been treated for osteoporosis? How long have you been on the treatment? Have you had a Dexa scan? What are your risk factors? So we do a post-fragility fracture care to ensure that you're not at risk for this going on again. There's a large gap in follow-up care after a fracture. So we're trying to reduce that risk through here. We then follow up with you in the bone health clinic to get your Dexa scan updated, to go over a detailed history with you, to look at your risk factors, and then to talk about treatment options. It's a joint process. It has to be your input as well as ours, so that we can find the right program that's going to work for you to help decrease your risk. We can't, if we just give you a script for a drug and it doesn't work for you or you have a problem, it's not going to be effective. So we really try to work with you to find the proper program. Like I talked about, we track patients with fragility fractures. We have a registry. That's what the Only Bone program is. And it looks at, are the benchmarks for post-fracture care being done? Are you following up with a Dexa scan? We call you back after about 3 months after your fracture to check. Did you get your Dexa scan? Did you go in and talk to your doctor? Did you come see us about treatment options? Because we want to make sure that that care has been initiated. So I personally think 2 million fractures a year is way too much. So I would love to work with you and kind of reduce that risk factors for you.